Welcome back to Dr. Twyman's Ask Me Anything every Monday night, 6 p.m. Answering your cardiovascular questions all about health span, longevity, endothelial function, dyslipidemia, whatever you guys like. Some great questions today. Saw some red light questions, some lipoprotein questions, had a couple of risk calculator questions, so everybody answered them. So this Friday is my 5th anniversary. It's actually Thursday of opening Apollo Cardiology here in St. Louis, where we focus on the early detection of cardiovascular disease, basically helping people not have heart attacks and strokes since 2019. My great team of Dow and Cassidy, if you know them, you understand the backbone of the practice. They're organizing a birthday party on Friday, 4 p.m. to 8 p.m. here in St. Louis at Shaw Park. If you're interested today, the RSVPs will be closing so we can get all the orders in for the foods and drinks and such. But very grateful to all of you who've been on the journey with us. It's been a fun adventure, and I think we're basically just getting started. So tonight, going to answer some questions, trying a new pair of blue blockers. I don't even actually know what the model of these ones are. This is not a paid ad. I was sent these, so I will give that disclosure. But Tech, been a friend with that company for quite a while. I have a lot of their red light panels in my office. I used to use their Wolverine glasses until I had an issue with them, and they sent a couple out pairs for me to try out. So this is one I personally like. I'll try out the other one in a minute, and then I'll let you guys vote which ones you think I should be using as my new podcasting glasses for a bit. So first question up tonight. What is the relationship of thyroid and cardiovascular disease? So your thyroid has multiple components that affect the cardiovascular system. One of them is it affects the lipoproteins. If you're hypothyroid or underactive thyroid, you start affecting your LDL receptors, and then your ApoB particles tend to increase. If your thyroid is overactive, people tend to have more heart rhythm issues. They have premature atrial contractions, premature ventricular contractions, higher risk of atrial fibrillation. So you want to have an optimal thyroid function, and you want to have more than just your TSH checked. So you would want your thyroid stimulating hormone generally to be around 2. You want a normal free T4, a normal free T3. If they check it, your reverse T3 should also be in the normal range. Reverse T3 is an inactivated form of thyroid. And then at least once, if you have any concerns with your thyroid function, you should have your thyroid antibodies checked, the thyroid peroxidase antibody and the antithyroglobulin antibody. Make sure you don't have Hashimoto's or autoimmune thyroiditis. So definitely is something that I monitor in every single patient. If it's abnormal, sometimes you can work on getting proper sun exposure, getting gluten out of their life, limiting artificial light, getting more sunlight, or using red light therapy to improve it. But sometimes they do need thyroid replacement if they're low. Question up about removing saturated fats from the diet. How much will it move cholesterol numbers, specifically ApoB? It's individualized. I've seen saturated fat do nothing to people's lipoproteins, and I've seen people eating, would you consider a reasonable diet, maybe kind of a more fat-forward paleo type diet, and their lipids go to the numbers where it looks like they got familial hyperlipidemia. You can't really always predict it. But one thing that I would do is I will often use the cholesterol balance test from Boston Heart to figure out, is the person a hyperabsorber of sterols? Those people tend to have more issues with saturated fat. If you're an ApoE4 allele carrier, more issues with saturated fat. And it's one of those things where you want to kind of, test, don't guess, or I can say sometimes I'm from Missouri, you got to show me, is get whatever labs you're going to get, get your ApoB at baseline, and then make the dietary change and see what happens to your ApoB. Some people, it has a big effect, changing out saturated fat. Other people, not much at all. But if your numbers still can't budge, often ezetimibe or Zetia is a good option for those patients if they can't get to the goal with just lifestyle changes. Okay, this is a challenging question because I don't know all the details in it, but what potentially causes particle count to still be high even with a low LDL and ApoB? Does that still matter? Well, let's just back it up a little bit. It depends on which particles you're speaking of. The atherogenic or the plaque-forming particles are going to be the ApoB containing particles. Those are going to include LDL particles, VLDL particles, so very low density lipoproteins, intermediate density lipoproteins, which are usually transient and not picked up in labs, and then LPLA, if you have it, which up to 20% of the population has high levels of LPLA. Side note, I did a podcast with Dr. Fitz Made to Fit. Her podcast with me just got released today. It's on her YouTube channel as well. So just go back into my stories and you'll be able to get a link to that podcast where I go pretty deep into Lp(a). But you want to kind of look at the total number of particles that have ApoB. So by reading your question, it seems to be that you have, quote, normal LDL particles and you have low LDL. In that case, you must have high VLDLs if you still have a high particle count. So particles do predict risk, but the ApoB is a better predictor, so I would follow that if there's any discordance between your particle count and ApoB. All right, there's a question about the cardiac risk calculators. Which one do I prefer and why? I use them, but I don't make a lot of decisions on them because they are just that. They're calculators. They're trying to predict risk, where I want to actually know if you have plaque in your arteries. So that's why I do testing that looks at endothelial function. So I do the EndoPAD test on my patients in the office that looks at how much nitric oxide their arteries can release when there's a stressor placed on the system. I do pulse wave velocity, how stiff are their arteries, and then do testing that looks at the arteries themselves. So the carotid intimomedial thickness scan, or CIMT, tells you if you have soft plaque or hard plaque in the carotid arteries. And then either a CT coronary calcium scan or a clearly CT angiogram to look for plaque in the coronary arteries. Because you're wanting to treat the plaque, not just a risk number. Now, people need more data to kind of decide if they're going to be more aggressive. Then often I will use the AstroCharm calculator because it actually takes into account the high sensitivity CRP, which is an inflammatory marker, and you also put in the calcium score results. And it'll give you the risk of your events over the next 10 years of having a cardiovascular event. You can also use the MESA calculators. They're pretty good too. They will give you, kind of another number that gives you a vascular age, and compared to your peers, what percentile you're in. So usually the MESA or the AstroCharm calculators if I'm going to use them. But some of the challenges with those calculators is that for the most part they're only 10-year calculators. So if you're plugging somebody who's 55 years old into one of these calculators, well, most of the time people want to live into their 80s or 90s. These calculators aren't going to predict risk, and risk just keeps stacking as you age. So it depends on the person's age where if they're really useful. If you're plugging a 20-year-old's value into an AstroCharm calculator, the risk is going to look very low. But if they have endothelial dysfunction and they got high Lp(a), that person's higher risk than that calculator is going to pick up. So you're going to start treating them more aggressively at that age. All right. Grounding mats in a grounded outlet. Can't read that one. A bedroll, yes or no? I'll just say a qualified maybe. So, it really depends on how well grounded your home outlets actually are. Some of these grounding mats, will sell you a little plug that you put into the wall and it says if it's grounded. Okay, not 100% sure if that's accurate. But I would go more by how you feel with it. Do you feel that you're more energetic? Do you feel that you sleep better? If you're using a tracker like an Oura Ring or a Whoop band, is your sleep better when you're using the grounding sheets? I can only share my own experience. I've had some patients have great experience with them, but the 3 times I tried to use a grounding mat while sleeping, I had crazy nightmares in the middle of the night, and I sleep awesome normally. So I ripped the thing off in the middle of the night and never used it again. Just my own experience. So buyer beware with these type of devices if you're plugging them in to the power grid. That being said, if you have the option, some of the times you can hook up like an alligator clip with a copper wire to the device, like the mattress, sheets, and then you run the copper wire out the window into a copper plug that's going into the ground. Then you're truly grounded. So if you can do that, that would be the upgrade. Question: which red light devices is best for those who work from home in front of a computer all day? An open window. I mean, that's being a little bit cheeky, but you get full spectrum light from the sun. For those that have seen me at my office at Apollo Cardiology, my office is all set out to be circadian friendly. So rarely will turn on the fluorescent lights unless it's absolutely pitch black in the middle of the day. So we're getting just natural light in, but glass filters out 40% of the red spectrum of light. So I add back red into my office. So I have a FireWave device sitting on my back desk, that's just adding light back into the environment. I'm not using it for photomodulation. I'm not trying to get a metabolic benefit out of using light. I'm just trying to add that red light back into the mix, essentially into the room. So that's what I use for at the office. But there are various vendors that make different red light bulbs. You can get one of those and just have it on in the corner. Light is going to be bouncing off the walls. You don't have to have it be directly in your line of sight per se. I just had a calcium score and scored at 104. What should I do next? First off, it depends on how old you are. If you're above 80 years old and your score is 104, well, that's pretty much expected. If you're a 40-year-old, that's 99th percentile. 99% of your value is lower than that at 40 years old. So age really plays a big role in that. Now, in all comers, 0 is the best. Over 400 is high risk. Over 1,000 is very high risk. And the highest score I've seen is 7,700 something, and I've seen somebody over 5,000 recently. So to give you perspective on kind of the range of the scores, if you're over 400, you really need to work with somebody, because there's not a better shot than not, but there's a risk that you have ischemia or lack of blood flow down one of the 3 coronary arteries, and you may need a stress test to figure out, is it still safe to kind of exercise at high heart rates. And then it's really about finding the root cause. Why is your body developing plaque and your body's calcifying the plaque? So, what are your nitric oxide levels? Do you have certain biomarkers that are depleting nitric oxide? Do you have increased oxidative stress or inflammation? Do you have elevated lipoprotein A? Do you have high ApoB? Are you insulin resistant? There's many things that drive vascular disease, but those are 3 big buckets: nitric oxide, inflammation, and ApoB. Start there and figure out what's driving it, and then pull back on those levers. And if you're interested in having us potentially work you up for it, my website, drtwyman.com, there's an application on that page, and one of my team members would reach out to you if you're interested. All right. And then little words. All right. Looks like a young person, 19-year-old man. Looks like an LDL of 184, an HDL of 47, triglycerides 135, and then VLDL 25, which would be normal. Looks like they have high transaminases or liver function, so or at least mildly elevated. So from the biomarkers, it does not appear that you'd be significantly insulin resistant, but you have to figure out what's driving the high liver function markers. So is it alcohol? Are there different medications or supplements that have a hepatic toxicity that you're on? Do you need to get a liver ultrasound to look for fibrosis of the liver or fat on the liver? Starting point. The lipids themselves would not be tremendously concerning for any type of major metabolic issue or familial lipid issue, but a traditional panel isn't the best marker, so you do need to look at the lipoproteins and check an ApoB level as well. All right, so those are the pre-submitted questions. I'm going to switch out the glasses to the other pair. This is pair 1. Then you can tell me what you think of pair 2. And I haven't even seen what these ones look like to me yet. These ones are a little bit darker, it seems like to me. All right. Seeing a couple of familiar faces here. Some people have come see me at Polycardiology before. All right. What markers indicate a hereditary problem with cardiac health? As a keto carnivore for 9+ years, I came back with a high calcium score. Okay. So there's 4 genes that I will often check, and then it depends on what other issues the person has. If they have a major lipid issue, often we'll do a panel from GB Insight, looks at over 120 different genes that affect the lipid metabolism. But the basic ones I always will check is ApoE as an echo. If you have an ApoE4 allele, keto carnivore tends to cause major lipid issues. I will look at lipoprotein A, which has a genetic predisposition. You just have to check that test once if you have high levels or not. 9p21, which is colloquially known as the heart attack gene. If you have 2 abnormal copies of that gene, it 4x's or 400% increases your risk of having a heart attack over somebody who doesn't have 9p21. And then KIF6. We'll check those 4 genes. But your genes are what you inherit, then you live your life, and then there's the things floating through your blood, and then there's what happens to your arteries. And so the most important information you shared was that you have a high calcium score. Okay, that means you had endothelial dysfunction at some point. The lipoproteins got retained in the intima, inflammation occurred, and plaque built up, and your body scarred it down and calcified it. You have to go digging into the root cause of what's driving that plaque. The calcium isn't the problem, it's what comes along with it. And that's what we obviously specialize in at Apollo Cardiology, is getting to the root cause of why people are developing plaque in their arteries and shutting those processes down. I don't know exactly what the question part is, but what is the effect of, asthma on the heart? Good question. I would think that it's mostly that, how much inflammation do you have would be the biggest concern. If you have a lot of inflammation, and you're on multiple inhalers and, steroids, those inflammatory compounds and interleukins and cytokines are being transmitted through your 60,000 miles of blood vessels. The glycocalyx of the arteries can be damaged from that inflammation. So that's probably how I would think about asthma in the heart. Can gum issues cause microvascular angina? Potentially, if you have, periodontal disease, can cause inflammation in the vascular system. And if you have, destroyed all your nitrate-reducing bacteria in your saliva, you may have lower nitric oxide. Most of your blood vessels are smaller than human hair. That's kind of what microvascular angina would be caused by, is the microcirculation can't dilate effectively from nitric oxide. So it could be affected. One test that I will look at is called LP-PLA2. It's also known as the plaque test, or PLAC. If that level is elevated and you don't have a ready cause for it, sometimes it's due to an oral infection. Seen a lot of familiar faces on here tonight. Just looking for some more questions here. Question: are stress tests dangerous? In general, no. I mean, it's supervised, and so it's no more dangerous than what would happen if you're exercising on your own. This is an instance where you have the benefit of a team that usually knows what they're doing if there's an emergency, versus exercising out in the wild and don't know if you have a problem. How long does it take somebody to get to you? That being said, any type of test where you push yourself to the max, there's always going to be a risk. I've personally never had a patient die on me doing a stress test. I've never had a patient have a heart attack while doing a stress test, but it's theoretical. I did have a few patients who had some very high risk stress tests where they had some abnormal heart rhythms and had markedly abnormal EKGs during exercise, and then on the cardiac imaging, they had their anterior wall was completely down. So we took them straight from the stress lab to the cath lab and found that they had severe blockages in their left anterior descending artery, and they got stented. But generally, stress tests are not tremendously dangerous. But that being said, you want to make sure you're doing it for the right indication or reasons. If you're having exercise symptoms, you're short of breath with exercise, you're having tightness in your chest with exercise, or just exercise is harder than it should be, then doing a stress test to see can you recreate it with exercise is one of the best ways to figure that out. If you don't have symptoms and you do a stress test, you'll generally pass the stress test, particularly unless you have severe plaque in your arteries, and often people are going to have symptoms that have severe plaque in their arteries, and that's usually greater than a 70% blockage in one out of three coronary arteries. Just because you pass a stress test does not mean you're low risk of having a heart attack. It just means you can pass a stress test. Stress tests aren't that sensitive to picking up plaque in the arteries unless it's severe. So that's why I kind of give it a big caveat. It's what is the indication? Why do they want to do a stress test in you? And then they can talk to you about the risk benefits of doing the stress test. Something about atrial fibrillation, but I don't know this part. Consistent electrolyte balance, i.e. LMNT. Do I think this could be beneficial? Possibly, but there's so many things that go into atrial fibrillation. It's usually an issue with oxidative stress, or it's an issue with microvascular dysfunction, not enough nitric oxide in the small vessels, or it's a thyroid issue. or something, untreated sleep apnea. So you got to figure out what the cause of AFib is if you can. If your electrolytes are off balance, if you have very low potassium or magnesium, but you have kidney issues, why do you have electrolyte imbalance? Element T can work for some people, but it has a gram of sodium. So some people are more salt sensitive than others. So can't say it's a blanket like it's safe for everybody. You have to know, does it cause edema or swelling essentially in your extremities if you're using those things. But typically you want to keep your potassium levels over 4 and your magnesium levels over 2 if you have any type of heart rhythm issue. Can you repeat the percentile explanation? Sure. So I think that was back to the person about with the calcium score. So it really depends on the age. If you can go into the MESA calculator and plug in your age with your calcium score, and it'll tell you what your expected score should have been at your age and your percentile. So it'll tell you if you're, for example, I'm 48, my calcium score is 0. So it's going to tell you okay, at your age, your percentile of having a positive score would have been blank. If your score is positive, it'll tell you how high you are compared to your peers. So, I've seen some individuals under the age of 40 with positive calcium scores, severely positive calcium scores. They're at the 99th percentile, meaning 99% of people will have values lower than them. So it looks like most people are voting for pair 1 right now. Somebody likes pair 2. All right. Switch back to pair 1 for a bit. See if I can actually read easier through these ones. Whoa, this is a hard question. I'm not going to be able to answer this one, honestly. It's been a long time since I've even thought about this problem. Somebody's asking about double outlet right ventricle with switch surgery with the Lancampate maneuver. Risk. There's always a risk of arrhythmias after these congenital heart disease surgeries. There's always a risk with the aorta and the pulmonary artery having stenosis afterwards. So I don't honestly remember the whole complication of that type of procedure. It's one of the things where it's like congenital heart disease is actually more common in adults than as kids because the surgeries are so good now that kids live long enough that they reach adulthood. That wasn't always the case, especially when I started my training. But you honestly want to work with somebody who's at an adult congenital heart disease clinic, who has access to all the surgeons, who can actually kind of talk about the risk benefits of every procedure. So here in St. Louis, I'm fortunate enough to have SSM Cardinal Glennon. I did my training right next door to them at St. Louis University. I did do a month of congenital heart disease with them when I was in my third year of cardiovascular fellowship, but it's one of the things where it's like I have an interest in it, but not expertise. But that's a very interesting question. That's probably the hardest question I've been asked cardiovascular-wise this past year. Is collagen supplements bad for the heart? No, it would not be bad for the heart, but it depends on why you're using the supplement. And if you're using it for your skin, hair, and nails, cool, go for it. But I often talk about collagen being like bonus protein. It does not necessarily count towards your daily protein goals. Most people, would benefit by shooting for about 1 gram of protein for pound of ideal body weight that they currently weigh. Example, if your goal weight is to be 150 pounds, you should probably be pretty close to 150 grams of protein a day. Question, do I support berberine for lipid management? It's a caveat of in the right population, yes. It is, a weak oral PCSK9 inhibitor, so it helps the LDL receptors clear the ApoB particles, but it's generally not that potent or strong and does not routinely get people to goal as monotherapy. Now, if people have glucose issues, they're insulin resistant, then there's a bit more reason to use berberine in some of those individuals. But there was a recent test that I did that looked at some epigenetics for some methylation patterns to tell you essentially like how old your vascular system is. And one of my markers looked sky high. It made it look like I was like, a 4-pack a day smoker or something like that. And then when we did some of the analysis with the team, it turned out that berberine probably messed up this assay. So does that mean something bad for my cardiovascular system? I don't suspect so. I think it's just going to mess up this lab panel. So I don't know exactly what to do about that for now. I may decide to kind of retest it with myself not taking berberine and see what does happen with that with markers. So that's why it's a big caveat. You have to work with somebody who knows the risk benefits of every medication supplement that's going into you. And if there's an abnormality that pops up on the lab, does it make sense? Because some of these supplements will mess up some of the labs sometimes. Any thoughts on, I think this is tadalafil for blood pressure, so Cialis. So it may help, but that's not its primary indication, obviously. Tadalafil, works on the phosphodiesterase inhibitor pathways. So it helps with erectile dysfunction, helps with pulmonary hypertension, helps with benign prostatic hypertrophy. It may have some effect on blood pressure lowering, but would not be first line. Typically the low dose is 5 milligrams a day, but this is where it gets challenging. There's not an indication for it for hypertension as far as I'm aware. So if you're just trying to take it for hypertension, you're probably not going to get it covered by insurance, as you're going to have to pay cash for it, for that reason. And there's better agents to work on first if you truly have hypertension. But do I see beneficial for some cardiovascular patients? For sure, but it's just not first line. Is low blood oxygen levels around 95 or under with microvascular angina happening? Is it a concern? Unknown for sure. I don't think the pulse ox at 95% is the main thing that's causing you to have microvascular angina. I mean, there's going to be something with oxidative stress or inflammation would be the more concerning thing. Can you get plastic surgery with a heart rhythm abnormality? This is going to be a caveat. This is not personal medical advice. This is in generalities. It depends on what heart rhythm issue it is, and it depends on what type of anesthesia. The surgery, there's always a risk of bleeding. There's always a risk of, infection. There's always complications that potentially happen. But honestly, the risk for most people is the risk of the anesthesia. Now, is a stress test always the best thing to do before a surgery? Not necessarily, because, play it out, stress test is normal. Doesn't necessarily mean you're at low risk of having a heart attack. I've seen plenty of people pass stress tests, have surgeries, and have heart attacks on the table. Or you see somebody get a stress test, it's positive. Now what do? Do you send them to the cath lab and you find something? What do? Do you stent them? Okay, you stent them. Now they're on aspirin and another antiplatelet agent. Now the surgery's canceled for bare minimum 3 months. But sometimes in the past, they used to cancel their surgeries for a year if you put a stent in somebody because you couldn't take them off antiplatelet agents. So you got to play it out like what kind of pre-op risk assessment do you need to do before the surgery? The best risk predictors really is how have you done with previous surgeries and what is your exercise capacity right now? If you're a generally fit individual, probably going to do pretty well with surgery. But if you're generally sedentary, that anesthesia is no joke. So you do need to work with a doctor who can do a proper preoperative risk assessment and then tell you, okay, you have this rhythm issue. That shouldn't be a big issue with surgery. If it's atrial fibrillation, well, often people will have more episodes of AFib after surgery because of the oxidative stress and inflammation of surgery, or just pain levels, high catecholamines. So they got to be treated with beta blockers or calcium channel blockers to slow the heart rate down after surgery. But it depends on if they're anti-anticoagulation, when do you come off anticoagulation? So there's a lot of moving parts with it. So you have to work with your cardiologist or primary care doctor to have a true answer. But in generalities, it's very rare that people are excessively high risk and should avoid all surgeries. All right. So, question or comment I say. Most quantum biologists say ditch supplements. Your thoughts? I'm always going to say it's always going to be dependent on the person who's sitting in front of you and how motivated they are to do all the things to optimize their circadian rhythms, to avoid non-native EMF, to, eat whole foods. There's so many moving parts for it. It's really hard to be all or none. Certain people, if they're willing to move, maybe they don't need as much. If they're willing to have an outside lifestyle, Maybe they don't need as much. But there's some people that just can't do that at this point. So you supplement what they can't get from optimizing their quantum biology lifestyle. But I do try to minimize it. The goal is, to always try to go to nature first. The concern sometimes with the supplements is, the quality, are there going to be contaminants? Is there issues with deuterium? There's some questions you can't answer. And so that's why you do want to minimize them unless there's no better options for it. All right. So there's one last question. I don't have enough information on this particular one. I've been asked it before. I'm going to have to do some research on it. I've seen it, marketed at a medical conference once, Fatty 15. I just don't really know, really the cardiovascular benefits at this time. So I'll get back to you guys on that one. So we're wrapping up. We're about the end of the hour. I do appreciate your guys' time and attention as always. These IG Lives, have been labor of love essentially for the past 3.5, 4 years. Started them right during the pandemic, and then they were only supposed to be a 6-week trial. And then I said, well, let's keep going, and it took on its own life. So at this point, I don't have my own podcast. If I do, I'll definitely let you guys know. I already have a name for it. It's called Mission 106 Plus. My grandma Ola, she lived from 1893 to 2000. I knew her. She passed away at the ripe old age of 106. It's my stated goal. I would like to try to beat her record, so go to 107. So if I end up doing the podcast, I'll let you guys know that. But for the interim, I'll keep doing these IG Lives every Monday, 6 p.m. Central Time. For those that are local, or actually I do see a couple people that I've seen from out of town come see me at Apollo, who've RSVP'd to my Apollo Cardiology birthday party. I'm looking forward to seeing you guys on Friday night at Shaw Park. It's been a quick 5 years, but I feel like we're just getting started, and I'm excited for the ride with you guys going forward. So hope you guys have a great week. Check out the podcast I just did with Dr. Fitz, the Made to Fitz podcast. It's all about LPLA and some of the cardiovascular risk factors we talk about here on these IG Lives, but it's in my stories if you need the link to that. So have a great week, guys.